with San Gregonio, and that's me. So we have a saying in vascular access that I always like to kind of stay grounded in, and it's the right line, right patient, right time. So we want to get the right access to the right patient for as long as they need it. Makes sense, right? So some things that I'll be covering, one of them is what is a PICC line. Everybody knows what a PICC line is, right? What is a midline? What's the difference between the midline and the PICC line? I'll touch a little bit on peripheral IVs, long dwell IVs, a little bit about care and maintenance of PICC lines and midlines, and CLABSI prevention, which is the central line associated bloodstream infection. So PICC lines, they're really a moderate to long-term IV therapy, which 5 days or more. So we don't want to put a PICC line in for a day, right? Continuation of IV therapy after hospital discharge. Patients can go home with them. They're also good for irritating vesicant IV solutions and or medications, and I'll kind of go over what defines an irritating or vesicant type solution. They're great for infusion of TPN, and they're also good for anything that's hyperosmolar solutions, which is 900 milliosmoles per liter. That's the definition of a hyperosmolar solution. And they can also be used for pressure injections and blood sampling. So does everybody know what pressure injection means? It means if your patient's going to go to CT, they can hook it up to that machine and slam that contrast in. So essentially, it's a very sterile procedure, as are midlines as well, but even more so with PICC lines because they are central lines. I mean, when you consider where the tip of the catheter terminates, it terminates in the chest, right, where a central line is. So it's considered a central line. So if you come across or come upon this scene, you know you want to at least put on a mask, okay? That's one of the other PICC nurses. So after we put the line in, of course we need to confirm. So I'm going to order a chest x-ray, wait for the radiologist, his reading, and then I will relay that information to you. So chest x-ray, you can kind of see it. It's right, I don't know if you can see it there, but that's where it terminates, right there. So I will then come up to you and say, hey, your PICC line is good to go. Yay, and you can use it. So I'm not going to just put the line in, get in my car and drive home. I'll let you know. And I do use some very advanced, we're lucky here at San Gregonio because we have this device, and it's called a vascular positioning system, or VPS. So it uses internal Doppler inside the catheter as I'm advancing it through the vessel, and it also uses an internal EKG. So when these two vectors intersect, that's when I get that blue bullseye. So I know I'm in the right place. Many hospitals that do use this, not all, but most, have even eliminated chest x-ray. That's how accurate it is, and it is FDA approved for that. It's more just a policy thing. We still do the x-ray at this point. So after the PICC line or midline is put in, I will identify, and this is an order set. You'll see this in the chart. It's going to say the date it was placed, which vein, right, left, the measurements of how much it's inserted, how much is external, and the arm circumference. So you can extract all of this information. It's going to stay in the chart under orders. And after I'm done placing it, the copy of this is going to go to pharmacy, so therefore Activase, CathFlow, and the BioPatch are going to be in the AccuDose, so you don't have to call the doctor and get an order for that. Any questions? No? So midline catheters, I'm going to explain. I think, does everybody know what the difference is? First of all, I don't want to over top a point if you kind of already know, but a midline catheter is shorter term. It's for patients that have difficult access. It can be staying in for about 4 weeks. So it's a shorter term. It's not for everybody, but it's great for patients that have, very little access. You can infuse most solutions, blood products and pain medications. However, the osmolality should be less than 900, so you don't want to put TPN in it. I don't recommend vasopressors. I don't even like PPN in it, because if you look at the osmolality, I actually called pharmacy here, and they said that the osmolality of our PPN is around 1200. So that's a really concentrated infusate. So you want to use non-irritating, non-vesicant infusates, and always use a 10 ml syringe to flush. And the best part is the old midlines we used to use, you could not draw blood from them. So these you can. They come in single and double lumen. So you can access it for blood, and you can also use it for power injection, which is very handy. And just so you know, whenever I get an order for a PICC line, I'm going to ask you questions like, how long does the patient need it? Why do they need it? And I'll ask you all the questions so that I have a better idea. Are they PICC appropriate? And I use a guide that has most of the most common medications that are given, and it'll tell me what the pH is. It'll tell me the characteristics of the medication. So I know if the physician orders a midline while the patient's getting TPN, well, we know that's not going to be appropriate. So I'll call the physician and say, hey, your patient is getting TPN. How about a PICC line? So I'm going to kind of do all that, research for you. You don't have to worry about that. So the basic difference is, where does the tip of the catheter terminate? So in midline catheters, it's going to terminate not in central circulation, it's going to end here, right about maybe a level of the axillary vein before you get into the central circulation. We don't want it past that, because then it's considered to be not a midline. It's just not best practice. So we always want it before the axillary vein. Does that make sense? Mm-hmm. Okay. So one's short, one's long, right? Who knew? There are some contraindications, and the reason why I want you to know this, especially ICU nurses, I don't think we have any ICU nurses here though. If you have a patient that has really horrible access, so the doctor says, oh, just order a PICC line, and come to find out the patient is a renal dialysis patient, and you've been waiting for somebody to come up and do your PICC, and we find out that the patient is on dialysis, we're going to say, not a good idea. So it's just kind of good to have in the back of your mind that that's really not appropriate. We should probably just get a central line. Have the physician put in an IJ or a subclavian or some other kind of access. Bilateral mastectomy patients generally are not considered to be candidates because of the risk of lymphedema. Of course, altered skin integrity would be another, not a good idea for obvious reasons. This is kind of a slippery slope, but I put it up here anyway. Patients with a high INR or low platelets, I don't like to have a cutoff, because then every case is different. Every clinical picture is different. So I'm going to look at all these labs, their coags, their electrolytes, all that stuff. I'll look at their renal function. If I think it's too high, I'm going to probably have the doctor fix it, whether we give blood products or platelets or whatever to fix it. So I don't like to have a defining number. And of course it goes without saying on cooperative patients, because it's a sterile procedure, you can't be moving around, you got to be a willing participant. A little bit about care and maintenance, very briefly. Always use a 10 cc syringe. I know that there's been some changes from what I've been hearing with Infusion Nurse Society, which is the governing body that decides best practice. They take studies and they put it into best practice standards, and that's how we define our policies. So the thought is that you can use a smaller syringe. However, I would caution you not to, only because the IFUs, or the product information, IFU is information for use, by the way. It does specifically say to use a 10 cc syringe. And if you fail to do that, and we have a catheter that becomes damaged because of that small syringe, then you'd be liable. So that's why I always say use a 10 cc syringe. And our population here is all adults anyway, so you're not going to be using little tiny syringes. Biggest thing that always my biggest pet peeve is coming in to check a pig and it's not clamped. There's clamps on it. Make sure you clamp them. It's not being used, clamp it. Shut the door. Don't let that blood come back into the catheter because it will clot. Very important. They're on there for a reason, right? As far as flushing, does everybody know, and the reason I ask is because I have come across, I used to be an educator for Arrow, so it always amazed me that there were quite a few nurses, whether they be new nurses, old nurses, the term pulsatile flush. They say, oh yeah, I know what that is, but then they go to demonstrate it and they really didn't have a good understanding of what pulsatile flush is. That's the push pause, you push, you pause. The last cc, you clamp off your line. What that does is it pushes that fibrant out of the catheter and it shuts the door so that that blood can't come back in. That's the true meaning of a pulsatile flush. And after blood draws, you always want to remember to flush with 2 10 cc syringes of saline because you want to get all that fibrant out of there. Check for patency of the line first by aspirating, making sure you do get blood in return, right? If it's sluggish and it won't aspirate but it'll flush, sometimes that means there's a little, fibrin at the tip of the catheter. And so when you apply negative pressure, anybody ever have that happen? And you can't draw blood. So I'm going to kind of go over this in troubleshooting, so I don't want to go into it too much now. Again, always use 10 cc syringes because the smaller syringes can exceed 300 psi, which is what the catheter is actually tested for. And you can't overflush a PICC line. Just flush the heck out of it. A little bit about midline and PICC line dressings. Generally, I change them all. I like to own all the lines. I even do a lot of the internal jugular lines too, because that way we know they're getting done regularly. They're changed every 7 days unless they're soiled, wet, loose, bloody. Then of course it's before the 7 days. Always want to use sterile technique, so a mask for the patient or have the patient look away. I know some patients don't really like the mask. And it goes without saying, don't use scissors, right, for obvious reasons. Use extreme caution is not to dislodge the catheter. So when you take that dressing off, it's sticky. It could grab, at the insertion site. The catheter can come out, and that's obviously bad on so many levels. And make sure you always change the stat lock. Here we had an issue with nurses. Oh, the stat lock looks fine. Just put another tegaderm occlusive dressing on there and call it done. But that's going to hold in microorganisms. So biopatch blue side up, right? And when you change the dressing every 7 days, you also want to change those little injection caps too. So this is what it should look like. You see the catheter's completely covered. Now the PICCs that we use are typically not trimmed. They come in various lengths. So if I have a 5-foot little old lady, you're probably going to have some out. So keep that in mind. That's normal. But we do have something with there, what's called a second sight. It's this little blue and yellow thing. So what that does is I put that on usually if there's more than 5 centimeters out. And that'll keep the catheter from pistoning. So it'll kind of secure it 2 centimeters from the site. Makes sense, right? Mm-hmm. So that stat lock, everything has to be covered. Coban, we love Coban. I know, I admit it, I love it too. However, it can be very bad. First of all, it turns into a tourniquet, right? This patient was an ICU patient where I guess it got pulled out. And this is not to condemn anybody. The nurse did what she had to do. And the Coban at that time was okay because it was very temporary. I was going to come up and do an over-the-wire exchange and replace the line. So, but I want to talk about it because it actually is written into Infusion Nurse Society standard practice. Do not ever use Coban on IV lines or PICC lines. It is not good practice. So I was kind of surprised they actually put that in the SOP, or the standards of practice. So this line here, you can see, this isn't covered. I don't know if you can see that, but that little spot right there, that can, I mean, hospitals are dirty places, so that can get microorganisms on there that can, you know, grow and infect your line. So I think the takeaway here is you just want to make sure it's all covered. That's all I want to show you. And it's not clamped. So, any questions so far? No? Never use scissors near a PICC. This actually happened. I got a call, oh, patient got caught on the side rails and it broke. So, I mean, clearly it's cut. So, and it could happen, and probably more than likely, if you wrap it with, you know, Coban or Curlix or something of that nature, I'll just cut it off. Well, be careful because it can look like that. Now you've got a line that's open, right? So, we clamped it. I actually took this one out of the patient and replaced it. So, all was good. This patient really did pull their PICC. And I'll tell you, these catheters are very durable. It is virtually impossible to break them. So they're very, very sturdy. If anything, it'll stretch. You can see every increment is a centimeter. So this one really stretches it. Oh, it's not flushing well. It's really, really sluggish. So lo and behold, it was pulled. But this patient didn't need any more. They pulled it. I've seen just about everything you can imagine. This one was a creative dressing, I believe, done by a radiologist. Not to pick on radiologists, but nurses are way better at dressings, as we know. Attention to detail. I fixed this one. The stat lock's not under the dressing, right? It's okay to put, and the reason I put this here, truly, not to pick on anyone, it's more because you see the blood underneath the dressing? That's okay for 24 to 48 hours. Standards of practice, got to be changed. So I changed it and I put everything under a dressing, so it was all nice. So this is, I'm just going to touch a little bit when we do change the dressing, why tip placement is so important. Because we've done studies and they've shown that catheter tips that are not within that lower 1/3 of the SVC have much higher complication rates. So I love this this piece here, but this shows the complication rates associated with lines that have either migrated out or maybe they weren't put in right in the first place. So the SVC is only 7 centimeters long. That's not very long. So even if it comes out 4, well, you're really not in, you could be completely out of the SVC, depending upon where the clinician left it. Typically, we like it down here, which is the CHA or the cavoatrial junction. And even just another couple centimeters up, it more than doubles. So for each increment, you can see 86% failure rate with the brachiocephalic. And we found that because of that, not being in that high flow area, they're prone to clots. And we also have found that there's a close connection between clots and infection. They tend to go hand in hand. That goes back to the whole biofilm thing. I don't know if you remember that from micro, but that's the reason why. We want to prevent collapsing, right, at all costs. I mean, not only is it an expensive complication, it's also can have a very high mortality rate, especially fungal infections. Fungal infections have the highest mortality rate. So at San Gorgonio, we use something called a ChloroGuard. So this is a ChloroGuard line, which is blue. Anytime you see a blue arrow product, we know it's a protected line. It's actually antithrombogenic and antimicrobial. This is all we use here. So I'll pass around so you can look. It's kind of nice to see what it looks like when it's not in the patient. This is a dual lumen by French. This one is not protected. So I'll let you look at that. Those are each 50 centimeters long. Any questions so far? So really the key to preventing CLABSI is truly care and maintenance. Always scrub the hub for 15 seconds prior to accessing. And that means a real 15 seconds, not just, okay, done. We do use the little Curo caps, those little green caps, so those are awesome. If they're on, I believe it's 3 minutes, then you don't have to scrub. I scrub anyway because I like to use I don't like to take any chances. Scrupulous dressing changes using aseptic technique, proper flushing technique, prevention of catheter inclusions, because remember I said how blood clots and infections tend to go hand in hand, and effective catheter stabilization and common sense wash your hands. Routine things can have some very dangerous consequences, so that's the reason why I did this little segment. We have something, first of all, called a long dwell IVs. This is all peripheral stuff. So the long dwell catheters are 6 centimeters long. I don't do a lot of them, only because a lot of our patients, they don't really meet the criteria for it, or their veins just aren't healthy enough to allow a 6 centimeter catheter to go in. You have to have a straight vein, you can't have valves, so they are placed by the vascular access nurse with ultrasound, sterile. So, but they are nice because you can draw blood from them. So if you do see one, you can draw blood from them and you can power inject into them, and they can last 3 weeks. So it's kind of nice. I think if I were in the hospital, this is what I would want. Mm-hmm. Yeah. And you can put just about anything in them, just not TPN. You can put Vanco, most medications, because if it infiltrates, you're going to know about it. That's why we don't like them in midlines. If you were to put something that causes extravasation, you're not going to know about it in a deep vein up here, and then you're looking at a lawsuit. So they can remain in place, like I said, 3 weeks. They're pressure injectable. They can be used for blood draws. And the reason for that, because the very tip, I actually have one, at least I think I do. It's called a fish mount, so it doesn't collapse when you apply negative pressure. I don't think I have one, sorry enough to say, but you saw the picture, you get the idea. I'm going to touch a little tiny bit on EZ-IO. I'm not going to go into it. I'm not going to tell you how to put it in, or just the basic things like locations. Primarily it's the tibia, right? I like to think big toe EZ-IO, so the proximal tibia, medial tibia. The new site we're using, well, I shouldn't say it's new, it's just better. It's the humerus. So if you work in a department where you place the EZ-IO, you can be signed off. Usually that's ER. Some of the nurses in ICU know how to do it. And this is what it would look like in the humerus. There are some steps that we take because everybody thinks, oh my God, EZ-IO, that's barbaric. How could you do that? That's horrible. And honestly, that's what I used to think. But then I started to really research it, and I thought, well, this is better than poking a patient 100 times, right? If you watch the videos, they have an alert and oriented gentleman who actually, I don't know if I do this, but he volunteered to have somebody put one in. He didn't even flinch. I don't know, maybe he had a couple of years before, I don't know, but I don't think I'd want to do it, but I tell you, I would much rather get this than be poked a bunch of times. But they do put lidocaine, preservative-free cardiac type lidocaine, and that marinates in there so that it's numb. The biggest thing that hurts with the EZ-IO is you have to push that fibrin mesh out of the way. So they slam it with 10 cc syringes. That's what hurts. So it's not really the insertion, it's getting that fibrin mesh out of the way. So just a little FYI. Removal, you might have to remove one. The way I always tell people is pretend you take like a water bottle and you invert it, hold it, clockwise, pull. No rocking, right? Just pull straight out, just put a Band-Aid on it, done. And that's pretty much all I'm going to talk about. Oop, and I must be out of sequence here. Sorry. This is a long 12 IV, just if you wanted to know. That's what it looks like. It has a bio patch. It can be below the elbow, and it has a stat lock and a bio patch. And it'll clearly say long 12. I'm usually really good at documenting stuff. These are some considerations for peripheral IVs, and this is why I wanted to go over this piece, because standard IVs are usually, 20 gauge, 1 1/4 length, right? But for some veins, especially your elderly population, we're trying to put these into veins that are way too small. And so you might get blood return, you go, oh, it's good, you leave it, you start infusing, and it's gone. 22, 1 inch is usually sufficient for a lot of patients that are not getting a high volume of fluid, they're not getting rapid infusion of blood products. It's perfectly acceptable. Now, if you have a patient that's going to go to surgery or labor and delivery, you might want to have a 20 or an 18 gauge. But for your standard IV, for a patient with little veins, 22 is fine. And the reason for that is, first of all, you wouldn't put an ocean liner in a stream, right? So think of it that way. And if you look at the catheters, the IV catheters, it'll tell you clearly what the flow rate is on it. Believe me, I didn't know this up until I became an IV nurse. The 24 gauge has 24 mLs per minute. That's a little tiny one. That's over a liter per hour. That's a lot. And if you look at the 20 gauge, that's 3780 mLs per hour. You're going to be giving your patient that much fluid? Probably not. At 22, you can still deliver over 2 liters per hour. So, I mean, it's not, I wouldn't go around putting 24 gauges in everybody, but a 22 or a 20 is usually, ideal. Never use these veins. Anybody know why? I call these alternative sites. Believe me, I've seen IVs just about everywhere imaginable. I've seen them in the breast, I've seen them in the shoulders, heck, I even saw one in the buttock. I kid you not. Abdomen, we don't want to use those. And because, first of all, these veins are prominent for a reason, because there's an underlying disease process, or they're very high pressure. So when you put a little catheter in there, it's not going to last long. And who wants an extravasation there, or an infiltration? Very bad. This is a patient that I actually thought had, I'm like, is that a port? No, it's an IV. So it has an EJ, so I put a PICC line in this patient, but yeah, when I came across that, like, no, this is bad, take this out. I want to say, this patient was pretty sick, they had vasopressors. You would never want to put, especially that kind of medication, in any of those veins. This was not anything I personally saw, but I pulled it from a medical journal. And this was actually extravasation from, epi on a 63-year-old female during resuscitation. So they didn't check to make sure the line was good, and this is what we got. So I've seen blistering. It's really ugly, and it's a lawsuit. I mean, people have lost limbs, they've lost their breast, if that's where we're putting these. So if you can't get an IV in an extremity, then I recommend you call the doctor and just be very firm and say, listen, we've tried everything. There's no way we're going to get an IV on this patient. And depending upon how sick they are, maybe we need a central line. I always say, just be an advocate for your patient. Don't be afraid to challenge a physician on something like that, because IV stuff can really go sideways. It can be scary. Something so mundane and routine can be, I love that face, by the way. A little bit, I'm not going to go into a lot of PICC troubleshooting, but every now and then you're going to come across a PICC and you're going to go, oh great, now what do? I can't get anything in it, I can't get anything out of it. What do I do? So the first thing is, I always say, check for mechanical cause first. Don't go run into the bedroom to get cat flow, because it might be something simple. I've had a patient, I put one up in ICU, I get downstairs, the phone rings, our PICC line won't flush. And I thought, I just put it in. Well, we're going to try cath flow. I'm like, no, I just put it in. So I went back upstairs. Lo and behold, it was just kinked a little. So I took the dressing off, using sterile technique, of course, put a new one on, perfect. So always rule out it's not mechanical or some other cause like that. When you flush the line, if you can flush the line and you see leaking, that's never a good sign. Usually that means there's a blood clot somewhere along that path of that vessel. So the infusate is backtracking out. That's never a good sign. Even on your IVs, you know, your peripherals, how they leak, that's why. Other things that can cause a obstruction are drug precipitates, crystallization. Never put dilantin in a PICC line. Does anybody know why? Because it forms a precipitate, and it's a long, skinny tube, so that's why we don't want to put IV dilantin in it. If you've ruled out everything, then get the cath flow. It really is, it's a miracle worker. If you don't know how to put the cath flow in, call me or whoever's here, and they can do it for you or show you how. The biggest thing I always go to is I Save That Line. This is put out by Association of Vascular Access. They are the governing kind of agency organization for nurses like myself that are very involved in IV access, and you can certify and you know, get all your CEUs and stuff from them. They're very, very educational. So they have this little thing that's I Save That Line. And the biggest thing for me is this one, vein preservation, because veins are not a renewable resource. Once we start, you know, hitting veins all the time, they become sclerosed and they thrombose. Once a vein is thrombosed, it's usually never good for the rest of that patient's life, typically. And that's why I go back to the renal patient. They're getting dialysis. Their veins are their lifeline. So when I used to work IR, sometimes we had the same patients coming through all the time to get their catheters put in, and I would look at their veins in their neck and their veins and go, uh-oh, they don't have any veins here. They're not collapsible, they're not compressible, so I know they're probably thrombosed. So we want to preserve veins. And doing all these steps to really, you know, best practice, essentially. This is what the, remember I told you sometimes you aspirate and you can't get a blood return. The first one is an intraluminal thrombus. It's kind of nice to get a mental picture of what it looks like. Fibrin tail, that's the one where you apply negative pressure and that little thing flops down and you're not going to get, you can always flush it, but you can't pull back, negative pressure. Mural thrombus, fibrin sheath. I'd like to think that we don't really have a problem with this one. It's more like a complete sheath all the way up the catheter. And the reason is these, like I said, are chloroguards, so they really inhibit thrombosis. I haven't really seen much thrombosis since I've been using these, which is good. I haven't seen too many blood clots. I think I saw one in the 4 years I've been here. This is how you do cath flow. I'm not going to go through this, but there are some little cards that are available. I don't know if they're still there. But I have a few, and it just shows you how to do it. We used to do it with, does anybody remember, has anybody declotted a line before? And they used to use that little three-way stopcock. Did you do it that method? Because we used to do it that way. You had a little three-way stopcock, and you would put the syringe, put the cath flow, and try to work at it. Now they don't say to do that.
You just conceal it.
Yeah, now that's what we do now. It's a lot easier. The three-way stopcock thing made my head explode, so I was glad when they got rid of that method. So yeah, you take the, you actually take the end of the, you know, the clave or the port off and go directly to the line and just negative, positive pressure. Heck, I stood there 15 minutes getting cath flow in, but once it's in there and it marinates in there for 30 minutes, you go back and it's like, woo! It's wonderful stuff. Points to remember, PICC lines are central lines and do require a physician-informed consent. So if your patient needs a PICC, make sure if the physician's, you know, just right, you know, we need a PICC, go in and talk to your patient, or if the patient's ventilated or whatever, not able to sign a consent, make sure they have a conversation. And sometimes the physicians will tell the patient or tell the family or whoever's responsible, and they will document it in the H&P. They'll put plan, insert